Hello and welcome everyone to this session about implementing a collaborative self-management plan for patients. Just a quick note, the session or the video is pre-recorded. After that, there will be a live Q&A session as normally. So I hope you enjoy the video.
How can we provide technology that enables and empowers patients to better take care of their own health? That is the big question we are asking ourselves every day. Today I'm going to go a peek into the implementation of a collaborative self-management plan for patients, which is a tool for patients to understand and treat a long-term condition by themselves. My name is Ingvar Soerlien, and I work as a digital solution lead for e-health and remote patient monitoring in the Nordic and Baltic region at Siemens Healthineers. Here I have the pleasure to work in an intersection where medical devices meets healthcare IT and where technology meets people. A self-management plan is a tool that has been in use for a couple of decades to help patients with a long-term condition, and the tool is now gaining more traction in the clinical implementation and in research. The core concept is that the patient himself is the person that best knows his own symptoms, and with proper education and guidelines, they are also best suited to make decisions about their own care and treatment. This is a paper-based template for a COPD self-management plan created by the Norwegian Heart and Lung Association. The plan is made to be an easy-to-use tool for the patient with a traffic light style division. The patient are looking in the second column to evaluate their symptoms and possibly measurements to find which zone they are in on a current day. Based on the zone of the day, which is either green, yellow, or red, they review which medications to use and what activities to perform or not perform. There are several actors involved in a patient's self-management plan. It is often created by a home care nurse, then it's approved by a patient's GP, and it's of course viewed by the patient itself. At a later stage, it can be updated by the lung specialist at the hospital. All the actors belong to different healthcare organizations, and the self-management plan can therefore not be established as a departmental system. To make a digital implementation of the self-management plan, we needed to consider a flexible architecture, and the choice of international standards is ingrained in the way we work. We considered different options, but the choice fell on using a RESTful HL7 FHIR backend with smart authentication and authorization. This allows us to easily utilize national identity providers for both patients and healthcare professionals. It also gives us great flexibility in the way that in the future, third-party apps or EMRs can utilize our CarePlan service, and we can even utilize our app on other backends. For interoperability, we expect there will be national implementation guides for care plans, including self-management plans. And we are already relying on other existing national profiles, like for example a patient profile. From a FHIR perspective, the self-management plan fits perfectly into the concept of PlanDefinition and CarePlan, where the PlanDefinition defines generic templates for patient groups, which is instantiated to a patient-specific, actionable self-management plan. The PlanDefinition defines the default zones for the patient, together with suggested activities. When making a self-management plan for individual patient, the template will be customized to fit the current patient's abilities and needs. The patient's personal goals are always considered, and the activities, medication, and dietary advice will be individually adapted to the patient. One suggested activity can, for example, be to walk for 30 minutes. That will not work for the patients that are in a wheelchair. Medications and dosages are also highly individual to each patient and will be added to the plan. I will not go into details of the application nor the process of creating the self-management plan for the patient, but I would like to quickly show how it works for patients to illustrate the underlying FHIR data structures. As soon as the plan is approved by healthcare professionals, it will be available to the patient in the patient portal. The patient will use the plan in a similar way to the one on paper. The patient will first assess their symptoms and how they feel today, and choose if they are in the green, yellow, or red zone. When they choose the zone, they will get the overview of what actions to take. The actions are structured into activities the patient should do, medications the patient must take, and the dietary advice to the patient. In FHIR, the activities are represented as service requests, medication as medication requests, and dietary advice as nutrition order. This overview must be easy to understand for the patient, even for patients with limited digital skills. The patient must understand the zone description and be able to act upon the content of the plan. To make sure this is the case, we have performed several usability tests of the application prototype. Implementing this service has been a great journey, and we have been challenged a lot to make a good data structure with the use of FHIR. We have tried to look back and see what are our most important learnings from the process so far. I would like to emphasize that FHIR is extremely flexible, both for good and for bad. It has not been a walk in the park to find the optimal solution for all challenges. It is also easy to overcomplicate implementation efforts in order to do things very right. But we have discovered that FHIR Chat is a great platform to gain substantial knowledge on the best practices. Because of the big flexibility, it's necessary to work agile when making implementation guides and FHIR profiles. Plan, prototype, test your prototype, and then redo. The great flexibility also makes it very easy to work agile. There's also a lot of knowledge embedded in the FHIR specification. We had a lot of aha moments when we understood what was the intention of the different fields and structures in FHIR. The downside is that it's not always obvious what was the intention, and it can sometimes require hard work to fully understand. At last, FHIR is not an interoperability standard by itself. I often hear people talk about FHIR in a way that it will support interoperability. It won't by itself. It's the implementation guides and profiles that brings interoperability. The big flexibility is great for developing new applications, but the flexibility and the ambiguity must be removed for interoperability purposes. This project is a collaborative development project where we are working close together with our partners to bring a usable minimum viable product to production. The main partners are several municipalities in Norway, in the Agder region, and in the Oslo region. So here are my contact details. You can find me in the Whova Apps speaker gallery or you can find me easily on the FHIR chat on Zulip. If you have other questions, feel free to email me or tag me on Twitter. So let's move on to the Q&A section.
All right. Thank you very much for your clear video. Very condensed. The questions still need to come in. Attendees will take some time to form a question. So in the meantime, we could already start with, or you had some material that you can elaborate on. So you can unmute yourself and turn on your video. And you want to share your screen as well. So I will stop sharing mine and then you can take off.
Yes. Thank you so much.
No problem.
Yes, I can elaborate a little bit on this architecture because in a 10-minute presentation, there's not much, too much room for elaborating on things. One very important aspect for this application, at least in the Norwegian context, is the ability to integrate to national identity providers. Because in Norway we have one identity provider for citizens. So every citizen in Norway has an electronic ID. And then we have an sort of extension to that one, which is made for healthcare personnel. So every healthcare person in Norway has an additional healthcare identity. And we must then support these identities. So every citizen will then use the national identity provider in Norway to log into the application, and the same with the healthcare providers. That is quite yeah. I don't know how many countries actually have that yet. I know that we have in Norway and Sweden at least. And it's emerging in different countries, but I think it's a very good service for this kind of usages.
Do you maybe have a clue if there's more European collaboration on this, or you just mentioned Sweden and Norway together, but
yeah,
maybe some more partners?
Yes, there are also more partners between the borders with this European electronic identity provider stuff. Yeah, so it is also possible to do it across borders. Yeah.
Well, it's good to hear that there's the plan for more collaboration.
Yeah.
I just need to go back to one slide for a moment. I saw a nice thing I wanted to ask a question about. Sorry, is there just it popped into my mind and now it's gone again. There were lessons or important learnings for yourself or for your team. Are there any points here that you maybe want to teach others not to make the maybe mistakes you made yourself or your team?
Yeah. At least in the start, we were a little bit anxious to ask questions on the FHIR chat, and I think that was one learning, that you should not be afraid of doing that. There are so many skilled people at the FHIR, the Zulip, the FHIR chat, and you can get so many good answers and really elaborate on your understanding of things. And doing if you don't really understand what was meant in the FHIR specification, then it's a good idea to ask the question, because then you can avoid doing doing some stupid mistakes. So that's a very good advice. Try to understand what is really meant. That I must emphasize that, because sometimes it's not really obvious, and I've seen the people implement extensions and doing a lot of additional works that was really not necessary, because things were solved in the FHIR specification, basically.
Is that also how you manage to not overcomplicate it? Because you mentioned that it's very easy to overcomplicate to find a solution. The FHIR chat is a good start to or a good source of knowledge, but did it also help you to not overcomplicate anything?
Yes, probably, but what is most important there is actually doing the implementation, because when we were first starting, we started to make sort of the FHIR spec or the implementation guide. Then we made a lot of things that were not so easy to implement, and needed to go back to the drawing board and actually redo what we had thought in the first place. And then we found much better solutions for the same issues.
All right.
Like,
So
for example,
oh, sorry, go ahead.
yes, to try trial and error. That is really important. Yeah, especially this zones thing. We had some discussions also on the FHIR chat. How should we implement that? And we were playing around with the different levels of care plans and a lot of complicated stuff. But then we suddenly found some fields in the different resources that we could use instead to make it easier. For example, in the medication resource, you have an as needed parameter that really is connected to this zone concept in the self-management plan. So you should, most of the medication you should only take if you get worse from your COPD, you should take some extra medication, and that is of course then connected to this as needed expression you have in FHIR.
All right. Is there anything else you want to discuss that you couldn't fit into your video?
I was hoping for a lot of questions.
Yeah, I guess maybe the presentation was so ultimately clear that no questions can be formed.
Oh, yeah.
Or just take some time to come up with a decent question.
Yeah, it was hard to find the right level for this kind of presentation, because it's a very complex issue in one way, but in the other way we needed to make it high level enough to fit it into the 10 minutes.
Yeah. Actually, I missed a question. I'm sorry for that. It was asked 5 minutes ago already. I will just read it out loud. This is super interesting as we're implementing something very similar. Would you mind going into a bit more details on the FHIR resources you used? Are there any examples I could look at, or are you working on any IG/profiles?
Yeah, I can do that. Yes, and that's of course a very good question. We have used quite some different resources, and I didn't prepare to go into detail on all of them. The main resources are of course the PlanDefinition and the CarePlan, and connected to this main group of resources, we have the activity definitions and medication order and such, and nutrition order, of course. And in addition, we of course are using the patient resource for the patient, and So the concept is that we have then defined the different activity sets that are sort of the guidance from the Norwegian bodies that make these guidelines for this kind of plan. And for example, the activity definition, we have then defined what the patient should do, like do a walk 30 minutes a day, or exercise for 30 minutes, and this kind of activities. And for the medication, medication is a very complex issue. So we needed to make it either very complex to add all medications and do it really properly, or we could just do it simple. So with the medication order, we have only using, more or less only using the medication, the administration field on patient instructions to tell the patient what they should do in this case. And then adding the more complex medication part will be done at a later stage. And for the nutrition order, we are that's all similar. That's the best. That's sort of the best field we can find. And nutrition order, it's in the current FHIR R4. It's really sort of targeted for in institution use, but it's changing. So for so it's going to be more specific for general nutrition orders.
All right.
Yeah, and we are working on the implementation guide. It's not finalized and published yet because, as I said, it's still work in progress.
Okay. There is one more question. We're 1 minute over time, but I think we can manage to put it still in. Are you able to use FHIR to integrate with the communal patient journals?
Yes, I guess they mean the journal system in the Norwegian municipalities in special. And we have not done that yet, so that is also on the to-do list. But there are some possibilities to send data to this municipal patient record systems with FHIR. But we are more concerned about working with the Norwegian document sharing mechanism, because we think that will bring more value on a short term, because that will enable us to share these care plans across the different Norwegian institutions without going into the details of the FHIR implementation. So we are preparing to share this patient care plans or these self-management plans as a FHIR document, so it can be viewed in the solutions that are not supporting the FHIR by itself, and also with of course the data structures in place, so it can be machine readable as well.
Right. Thank you very much. The questions are now starting to come in. Sadly, we ran out of time 2 minutes ago. So yeah, please keep asking questions after the sessions because, well, the question and answer section will still be open.